Yeah, Monica, sir has put it on live stream. I think we'll start 1827.
Okay.
Yeah. So good afternoon. I should rather say good evening to all. So welcome this Bajwa sir and Honorary Secretary ISA National. Then Dr. Nishant, Dr. Monica, and our coordinator Monica and Dr. Swati. And I request Monica to please start this today's proceedings. Monica, please take over.
Thank you, ma'am. I welcome you all to ISA online PG classes. And along with me today, we have Dr. Swati to moderate the session. So I welcome you, Dr. Swati, and I request you to please take the session ahead.
Thank you, ma'am. Good evening, everyone, and I welcome you all to the yet another session of ISA National PG Teaching Program. First of all, let us invoke the blessings of Ma Saraswati with the Saraswati Vandana.
Saraswati Namastubhyam Varade Kamarupini Vidyarambham Karishyami Siddhir Bhavatu Me Sada.
I request all participants to be in mute mode and not to disturb in between the presentations. You can put your queries or comments in the chat box, which can be addressed to after the presentations. We have two short cases to be discussed, hydrocele and meningomyelocele. Both of them pose unique challenges in terms of neuroanaesthetic issues, positioning, age-related issues, and also various congenital anomalies. We have Dr. Dheeraj and Dr. Himantika, both postgraduates from Sardar Patel Medical College, Bikaner, to present their cases, and examiners being Dr. Kantavati and Dr. Sonali Dhawan ma'am. Both are eminent teachers. Dr. Kantavati ma'am is a senior professor and former HOD from Sardar Patel Medical College, Bikaner. Madam's special area of interest include regional and pediatric anesthesia. Ma'am has more than 20 publications in her credit, and she's currently serving as president of Bikaner City branch of ISA. And ma'am has been a part of MD and DNB examiners several times, and she's been organizing secretary in Raj Isakon in 2018. And Dr. Sonali Dhawan ma'am also is a senior professor from Sardar Patel Medical College, Bikaner. Ma'am has been HOD before, and she's currently serving as honorary secretary from Bikaner ISA City branch. We are proud to have you both in our teaching session, ma'am. Over to you, Dr. Dheeraj. You may share your screen. Dr. Dheeraj is presenting or Dr. Himantika, ma'am?
Himantika is presenting.
Okay. Yes, you can share your screen, and over to you, Sonali, ma'am.
Thank you so much, ma'am. It's an honor for us to start. So we will not waste any time and just start the session.
Can you share the full screen? Share the whole screen. Put it on slideshow. Yeah.
Start.
Slideshow.
Is it visible?
No, it is visible, but it is the slideshow. It's not on slideshow.
Ma'am, it is on the slideshow. Please do it again.
Put it on slideshow.
First, put it on slideshow, and then you can share the screen.
Okay.
No, I'll tell you. Please stop sharing the screen.
Stop sharing.
Yeah. And open this folder in your on your desktop and make it slideshow without sharing it.
Okay.
Minimize the zoom and make it slideshow.
First is meningomyelocele.
Yeah.
Yeah.
Please open the folder and make it slideshow. Minimize the zoom.
Is it okay, ma'am?
No, we can't see anything still.
And then maximize the zoom and start sharing again. Are you able to do that?
Yeah, now he has started screen sharing, but the same problem exists.
Yes.
Ah, correct. Yes.
Yes, start, Himantika.
Yeah, start.
Good evening, everyone. I'm presenting a case of a 2-day-old male, PD of Atma Parveen, with a chief complaints of swelling on the back since birth. There is no discharge and the swelling is not increasing in size. Antenatal history, she's a 30-year-old primey with no history of fever with rash, no history of drug intake. Patient did not come for routine antenatal checkups. There was no history of folic acid supplementation and no similar illnesses seen in the family. Birth history, baby is born at term by elective LSCS, cried immediately after birth, weighing 3 kg. Apgar score at 1 minute is 8 and 5 minutes is 9. Baby passed meconium and urine on day 1. There was history of moving upper limb was present and lower limb weakness was present, which was tested by sluggish response on painful stimuli. On examination, patient was afebrile with a heart rate of 142 beats per minute, respiratory rate 46 per minute, saturation on air is 98%. There was no pallor, icterus, cyanosis, and no other anomalies. On spinal examination, there was swelling in the lumbosacral region of the size 4 into 5 centimeter, which is soft, cystic, compressible, with bluish discoloration, and was impending rupture. Transillumination test is positive. CVS examination, S1, S2 present, and there is no murmur. Respiratory bilateral air entry present with clear chest. Per abdomen is soft and non-tender. Perineal region is patulous. My provisional diagnosis is the term neonate with swelling in the lumbosacral region with lower limb weakness, most probably an unruptured meningomyocele.
Hanji, so Dr. Himantika, you have a 2-day baby and who has a lumbosacral meningomyelocele. So can you tell us what meningomyelocele is and what are the causes of meningomyelocele?
Meningomyocele is a neural tube defect. It is a congenital anomaly where the midline structures fail to fuse, and it comes under the spectrum of spina bifida, which is of 2 types: spina bifida cystica and spina bifida occulta. MMC comes under spina bifida cystica, where there is a herniation of the meninges and the spinal nerve roots from the vertebral arch cleft. Ma'am, the causes can be multifactorial. Genetic causes can be there, like trisomy 18 or 13, or there is parental or sibling with a previous neural tube defect. And environmental factors like there is folic acid deficiency, vitamin B12 deficiency, and some folic acid antagonist intake like sodium valproate or carbamazepine.
Okay. So now there is so much of advancement in the medical science. Can you tell us that is this congenital abnormality, can this be diagnosed before birth? And if yes, can we do something for the baby before birth itself?
It can be diagnosed intrauterine. we can estimate the levels of alpha-fetoprotein in maternal serum and amniotic fluid. And if the levels after 18 weeks, they rise up to more than 1000 nanogram per ml, it is positive that a neural tube defect is present. Also, we can see via USG that there is a cystic swelling in the lumbosacral region. When we talk about the advancement, there was a study known as MOMS, that is Management of Meningomyosine Study in 2003. They basically compared the in utero and the postnatal outcome of the surgeries. So they found out that there was the herniation of the brainstem at 12 months of age was lesser when intrauterine surgery was done, and more survival for BP shunting was less, and the walking of the neonate independently at 30 months of age was also capable in intrauterine surgery. But there were some disadvantages, as the mother had a premature rupture of membrane, and the mother had the preterm baby was delivered, and yet the outcomes are the long-term outcomes are not yet published clearly. So the research is still going on.
So let's hope for the best that a time will come then that we have that level of surgery that we can save these babies very early in utero, but still it is going on. So my next question to you is that now if you have this baby just after delivery, what precautions will you take before you get the baby to the operating room, like before even thinking of operation, just after delivery, what should the precaution should be?
Sorry to interrupt. Dr. Himantika, can you be a bit louder?
Yes, ma'am.
Okay, thank you.
Initially, I will stabilize the patient, and I'll take care about the position so that there is in the prone, or I'll keep it in the lateral position so that there is no rupture of the defect. The prophylactic antibiotics will be started, and latex precautions will be instituted from birth. And the defect will be closed with covered with a sterile saline soaked gauze so that there is no desiccation of the defect. And there will be a thorough neurological examination to assess any other deformity.
Now, what vitals do you expect in a 2-day-old baby? When we know the basic vitals, then and then only we can proceed for any kind of surgery or anesthesia. So what vitals do you expect?
Pulse rate will be around 100 to 160 beats per minute. Respiratory rate will be around 40 to 60 breaths per minute. Systolic blood pressure can be around 60 to 86 mm of Hg. Diastolic blood pressure will be around 40 to 45 mm of Hg. Mean arterial pressure can be calculated with the help of gestational age.
What do you mean by that?
Ma'am, like this neonate is 38 weeks, so the mean arterial pressure will also be 38.
Okay. So now you have this baby and you are planning for surgery, anesthesia. So pre-operatively, what all you want to do when you want to see the baby? What investigations do you want? What other things do you see? And is this associated with some kind of other malformations or something?
Mostly these cases are associated with malformations like Arnold-Chiari 2 malformation, where there is herniation of the cerebral vermis, the fourth ventricle through foramen magnum, and it might lead to brainstem and cognitive dysfunction, and which leads to swallowing difficulties, apnea, stridor, and in the cases which are associated with Arnold-Chiari lead to obstructic hydrocephalus in approximately 70 to 80% patients, which needs BP shunting and multiple revisions. Also, there may be neurogenic bowel and bladder, and sensory and motor loss can be there depending upon the level of lesion. Some orthopedic anomalies like clubfoot and hip subluxation and dislocation can also be there.
So very well said. Basically, what is said is that gastric, cardiac, and genitourinary anomalies are maximum associated with this kind of MMCs. So now you know that all this can happen. So what investigations would you like to have for your patient?
The basic, ma'am, I'll go for CBC, HB, platelet and WBC count. I'll go for urine routine microscopy, and I'll go ECG and serum creatinine, electrolytes, and 2D echo.
2D echo, I understand that we are saying that there are so many cardiac anomalies. With 2D echo, do you want to have an ECG too, and that too in a 2-day-old baby?
Yes, ma'am. As ma'am, neonates are mostly they are prone for long QT syndrome, and it is the leading cause of sudden infant death. And ma'am, even the perioperative stress as well as some anesthetic drugs, they are more prone for prolongation of the QT interval. So, and it can be an option in neonates, and also it is a non-invasive procedure, so it can easily be performed.
Very nice. So we can prevent few sudden cardiac deaths if we have a pre-op ECG even in a 2-day-old, 1-day-old baby. So very nice. So now what instructions will you like to give a night before for this baby?
I'll inform about the being fasting, the fluid therapy, and temperature, so that the baby should be covered properly. I'll go for a blood cross match and blood grouping. I'll take an informed consent to the patient.
Informed consent is very important here, because not only we are taking a permission. This is called informed permission also, and we must tell the parents that in spite of getting the surgery done, the patient can land up into hydrocephalous and might need another surgery also. So this is very important here. So now what are your major anesthetic concerns here?
Anesthetic concerns can be patient related or surgeon related. While patient related, we need to take care about temperature, the fluid, the blood loss, and
Latex
allergy. The latex allergy. And surgeon related, we can take care about the position and the blood loss.
Yeah. So there are obviously many, some are related to the disease per se, and some are related to neonatal age per se. Because in neonatal age, there are many anesthetic considerations which should be taken into account. Now, everybody says that neonates are not small adults. Do you agree with this? And in view of Airway, how will you explain this?
No, they are definitely not like adults. Airway differs as like when we talk about head, it is relatively large. So any anterior flexion will obstruct the airway. They are obligate nasal breathers. Their tongue is comparatively large, so there is difficulty in visualization of the larynx, and their epiglottis is omega shaped, and it is the axis is angled away from trachea, and their larynx is anteriorly placed, and it is higher as compared to adults, where it is placed at C5 to C4. And in infants, neonates, it's present at C2 to C3. Their trachea is funnel shaped, where adults' trachea is cylindrical, and their trachea is short. So with any this is non-compliant, so any pressure will obstruct the airway.
Yeah. So clinical implication is that we might find difficult airway in a small baby. And regarding to the respiratory system.
And respiratory system, they have due to pliable ribs, they have the lung the chest compliance as well as the lung parenchyma is very compliant. Due to reduced alveoli, the lung compliance is decreased, and due to the combination of both, there is a negative intrathoracic pressure. While inspiration, the chest wall collapse, and during expiration, there is decrease in the residual volume. Yeah. So overall, a fractional residual capacity is decreased, so that this leads to the decrease in the oxygen drive during the periods of apnea. So this leads to predisposes towards atelectasis and hypoxemia. Also, they have a higher oxygen consumption as compared to adults, which is twice the adults. and due to reduced number of alveoli and reduced lung compliance, to maintain the minute ventilation, they have to their respiratory rate is increased very much as tidal volume is comparatively fixed. Also, ma'am, they have their respiratory drive is underdeveloped, so they cannot respond to hypoxemia and hypercardia. They generally they'll have apnea.
So in total, why I asked about both the systems is that they are much more prone to go in airway obstruction, and also they are very prone for hypoxemia. So while doing the induction, we have to be very, very careful. So now you have to take the baby into the OT. So what monitoring will you do, and how will you proceed with everything, like step by step?
My patient is taken into OT. The OT temperature is kept ambient from 28 to 30 degrees Celsius approximately. Then the PAC will be reviewed, consent will be checked, and the defibrillator, atrial cart, and suction catheter will be checked, and they are working.
Yeah, this is very important. We anesthetists only have time to prepare beforehand. After this, once there is chaos, we can't buy time. So this is very important for every PG to understand that the preparation is the most basic and the most important thing. Yeah, carry on.
Nilper status will be confirmed. IV line access will be checked. Ma'am, then I'll attach all the monitors like heart rate, SpO2, ECG, and blood pressure. Then ma'am, I'll check the urine output, temperature.
Maybe Mantika, just interrupting. You said that you will take care of the heart rate. I just want to know, is there something specific about neonate regarding to heart rate?
Yes, ma'am, definitely. As neonates, their left ventricle is non-compliant, so it is not able to increase the cardiac output. So to increase the cardiac output, basically, and their stroke volume is also fixed. So Frank-Starling law is not operational in them. So to increase the cardiac output, they have to increase the heart rate.
Plus, the parasympathetic system is very prominent. So if there is any stimulus, noxious stimulus, they will go into bradycardia. And this bradycardia is very fatal in the kids. It can lead to asystole. So we have to be very careful here. So one more thing I want to ask, that like this baby is just 2 days old. There's something which is very important regarding to the circulation that we must know?
Yes, ma'am. There can, ma'am, while in utero, there is patency of the foramen ovale and the ductus arteriosus, due to which the lungs are bypassed and the pulmonary vascular resistance is decreased, and there is vasoconstriction. But after birth, the foramen ovale and ductus arteriosus close, and the circulation is started. The oxygenated blood is given via lungs. But in conditions like hypoxemia and hypercardia, the pulmonary vascular resistance is increased, which leads to vasoconstriction, and due to this, there will be increase in the pulmonary pressures, and there will be reopening of the foramen ovale and the ductus arteriosus. So there will be from a right to left shunting will be present. This will lead to the decrease in the pulmonary blood flow, and it will lead to hypoxemia.
And this hypoxemia is very difficult to treat. It is a persistent kind of hypoxemia. Can we treat this?
Yes, ma'am, we can treat it by hyperventilating so that CO2 can be washed out.
Okay, that's very nice. Now, will you take care of glucose in these babies?
Yes, ma'am. They are prone to hypoglycemia, as they have a very limited glycogen storage in the liver. So when the day first less than 30 mg per DL is considered as hypoglycemia. Later on, less than 45 mg per DL is considered as hypoglycemia. Okay, so we'll take care about it.
Okay. Now, basic monitoring you have said. Is there any other monitoring that you will like for this baby, or just for purpose of knowledge? Can you name some other monitorings also?
Yes, ma'am. There are some advanced monitoring like SSEPs, MEPs, NIRS, spectral fluoroscopy. And
Basically, we can go for EEG and this, but in such a small baby, they do not predict the depth of anesthesia and are also not very helpful. Only the NIRS can tell us about the oxygenation. So we can, if it is available, we can use that. So now coming to the anesthesia part. Starting with induction, how will you proceed?
I'll pre-oxygenate the patient. Then I'll give the pre-medications. I would use injection atropine in the doses of 0.02 mg per kg and injection fentanyl as a 2 microgram per kg doses. Then ma'am, I'll further proceed with the induction technique.
And which induction technique will you prefer, IV or inhalational?
Ma'am, as my IV line access is present, I would go for IV induction.
Okay, so now we have talked a lot about the airways and the respiratory system, that these patients are very prone to hypoxemia. What kind of precautions are you going to take so that you don't land up in hypoxemia with the baby?
Ma'am, I would like to use the controlled rapid sequence induction.
What's that?
Ma'am, previously classic RSI was used, but nowadays controlled RSI is used. Here we pre-oxygenate the patient and they are induced with hypnotics and the non-depolarizing muscle laxants are used. The airway pressure is less than 12 centimeter of H2 is applied, and ma'am, then there's no in classic RSI pre-oxygenated patient was pre-oxygenated, and while hypnotics succinyl choline was used, cricoid pressure was applied, and and in this there is decreased chances of oxygen desaturation without increasing the risk of pulmonary aspiration.
What do you think? Why have they changed it from like using of the succinyl choline to etraquinone here?
Ma'am, succinyl choline has a very rapid, it is water soluble, it has very rapid solubility. And as extracellular fluid is more in neonates and their volume of distribution is very high, twice as much as dose of adult is used in succinyl choline. Also, it might lead to cardiac arrhythmias like bradycardia, which are fatal for a neonate. And as in this case, there is muscle weakness in the patient, and so there might be rhabdomyolysis or hypokalemia, or it can also lead to malignant hypothermia or masseter spasm in certain cases.
So now you have given the induction agent. What induction agent did you say?
Ma'am, inject thiopentone in the doses of 3 mg per kg with injection atracurium in the dose of 0.05 mg per kg.
Why would you like to use thiopentone?
Thiopentone is a cerebroprotector, as it decreases the CMRO2, decreases the cerebral blood flow, and the ICP is also relatively decreased as compared to other agents.
And it is the best neuroprotective. We use it in ICU for neuroprotection also. So now you are about to do your laryngoscopy. Which laryngoscope will you use?
Being a neonate, I would use a Miller's blade of size 0.
Okay. So you will use a Miller's blade and then you will intubate the patient. Which kind of tubes? This is a very controversial area, but I would like to ask you, which kind of tubes would you use for this patient and for a little bigger patients?
Ma'am, the debate is about the cuff and uncuffed tube. So while cuff tubes give you adequate tidal volume generation, there are decreased chances of aspiration, decreased chances of laryngospasm, and the amount of fresh gas flow is also reduced. The needed reduced.
OT pollution is reduced.
OT pollution is reduced.
CO2 findings are more
accurate.
Precise, yeah.
And ma'am, those are not present with the uncuffed tube.
Yeah.
Yet we in our institute we've not seen such cases with any patients. Yeah. So in our institute we use the uncuffed tube.
Yeah. We use uncuffed tube, especially in neonates who are like you can count in days. For a little bigger pediatric patients, we do use cuff tubes, but we have been using uncuffed also. So now you have intubated the patient. Now what next step? Very important step will you take?
Ma'am, I'll the change of position.
No, first you have to auscultate and confirm the tube that you have placed.
I'll intubate the patient, then I'll confirm the tube of the patient.
What is the method? Like you always do your 5-point auscultation. Is there any specific method for neonates?
Yes, ma'am. The Mainstay method is there for the auscultation, for the confirmation of the ET tube. In Mainstay method, we auscultate the lungs, and we'll keep the stethoscope over the left chest, and then we'll advance the ET tube. So when we are able to not hear the breath sounds, we'll note that position. That means there is a transition from trachea to right bronchus. Then we'll note the position, and then we'll again withdraw the tube while we are ventilating and hearing the breath sounds. Then the point at which we hear the breath sounds again, we'll mark that point, and that point should lie from 0.5 centimeter from the previous position. So that means there's a transition from bronchus to trachea. And from this point, we'll for a neonate, we'll keep 0.5 to 1 centimeter above, so that there's bilateral equal sounds, and it'll be the tube will be confirmed that both lungs are ventilated.
Because this is such a small baby, we do not want that tube should be either too much inside or too much outside, or while positioning, we can accidentally extubate the baby or accidentally go for the endobronchial intubation. So now you have done this and you have fixed it on the angle of the mouth very precisely. What about maintenance?
Maintenance, I would use a mixture of oxygen and air with sevoflurane and the intermittent doses of non-depolarizing muscle relaxant. I'm using atracurium in the doses of 0.01 mg per kg.
Is there any benefit of using sevoflurane?
Yes, ma'am. Sevoflurane has a decreased blood gas solubility. So there is a rapid induction of sevoflurane. Also, it has a peculiar feature that its MAC is constant in neonates as well as infants. And ma'am, some disadvantages are also there, as it leads to emergence, agitation and delirium.
What's that?
Ma'am, emergence is when the child is emerging from anesthesia. So it becomes agitated, might be due to fear, the anxiety, or due to full bladder pain. And so initially we'll rule out these causes. If the agitation is still persist, we'll close the sevoflurane before emergence and give propofol in the doses of 2 to 3 mg per kg. This will relieve the agitation of the child.
Now you have done your maintenance. Now what about, tell me something about the fluid therapy for this baby.
Fluid therapy in this case, baby's 2 days. So in our institute, the fluid therapy started from day 1 as 60 mg per kg per day. So, and it is implemented to 10 to 15 ml per every day. So being day 2, we'll take as 75 ml per kg per day, and the fluid therapy will be started. And as there is no deficit, so intraoperatively we'll only go for the maintenance therapy, which will be calculated as 4 ml per kg per hour, as the baby is less than 10 kg. And for replacement also, we'll go for replacement flosses, which our surgeries can be classified as moderate to extensive, depending upon the lesion. So as we take it as moderate, so the fluid will be between 4 to 7. So we take it as 5 ml per kg.
Which kind of fluid would you like to give for maintenance, preoperative, and for replacement?
Preoperatively, in our institute, we give D10. And for maintenance therapy, I would like to use an isotonic solution like ringalactate.
What other solutions can you use?
0.9% sodium chloride can be used.
0.45% sodium chloride can also be used. 0.9% plasma light can be used. But it is as a protocol, we are using ringalactate in our solution in our institute. And plus, if there are any signs of hypoglycemia, then we start with 1 to 2.5% dextrose. Very right. So that is about your fluid therapy. And what about post-operative?
And post-operatively, we'll start with the enteral feed as soon as possible, and then the whole day maintenance therapy will be continued.
Okay. Tell me something about the blood loss that you will estimate, and when are you going to transfuse blood to the patient?
Ma'am, the blood loss will depend upon the mean alveolar blood loss, and it can be maximum allowable blood loss, and it can be calculated as estimated blood volume into hematocrit high minus hematocrit low into hematocrit average. This can be calculated.
Like this is a 3 kg baby. So what will be EBV?
Ma'am, EBV will be around 80 to 90 ml per kg. So we can take it as 85 ml per kg.
Okay. So roughly we take it like initial was 50 and we want to keep it to 40. So it will come around.
Ma'am, it will come around approximately to 50 to 55 ml will be the allowable blood loss.
So till this, what are you going to do?
Till this, we'll only go for the crystalloids, and when 30 to 50 ml per kg of crystalloid is given, then we can go for colloid also. In colloid, 5% albumin is used in our institute, and then we can switch to the blood.
Yeah. If you are still expecting that further blood loss is there, then and then only we'll go for the blood. And at least we'll keep 20 to 25% of hematocrit in the baby. So what is massive blood transfusion?
Massive blood transfusion is more than 50% of total blood volume loss in 3 hours.
So now we have discussed about fluid therapy, everything, patient is induced. Now we have to do the positioning of patients. So what precautions will you take and how will you position this patient?
Initially, while induction, the position will be supine. So as the defect is in the spine, so we'll keep a gel-based donut ring over the spine so that there is no rupture of the defect. And the rolled gauze will be placed over the shoulder and the head for the support. And the patient is induced. While after induction and after for maintenance and for the surgery, the patient will be taken in the prone position. So for prone position, the airway will be checked and the airway will be secured properly. All the bony prominence will be padded properly. Eyes will be padded properly. And the abdomen will be set free by placing the pad over the chest and the pelvic region.
Yeah. So as soon as you are finished with your positioning, what you must do?
Ma'am, I'll check my ET tube again, and then ma'am, I'll see if the patient is not turning into getting the hypoxemia. And
first of all, if you have disconnected in any case, you must not, but if you have, you should connect and you should auscultate for the heart, and then you should go for the auscultation of your tubes. Okay, so now your surgery is going on and you have a sign of hypotension. So do you think it is like in adults, you can take it coolly, or will you get alert by this?
Ma'am, hypotension in a neonate is actually an ominous sign, as it indicates that 20 to 25% of blood volume has been lost.
More than 30.
More than 35%
has been lost. So anytime you may be in trouble. So now if we assume that you are in a grave situation, like cardiac arrest is there, so what are you going to do?
In cardiac arrest, ma'am, initially I'll rule out all the airway causes and I'll check for the brachial and the femoral pulse. Then ma'am, if that is also not coming or it's feeble, then I would I'll start with the chest compression. It will be done with the
first you have to make the patient.
First I'll change the position into prone, as even the
is in the prone.
sorry,
you have to
supine.
Yeah.
I'll change the position to supine so that I can start with the chest compression, and I'll start the chest compression with the two thumb encircled with of the hand. The chest compression to ventilation ratio will be 15:2, and the chest compression depth will be 1.5 inches, and the rate will be around 100 to 120 beats per minute. And though this child is intubated, so the breaths given will be around 8 to 10 breaths per minute. And I'll start with the chest compression. Then I'll
See the ECG.
I'll
kind of.
see the ECG and assess if it is a shockable or a non-shockable rhythm. If it is a shockable rhythm like a VT, then I'll go for the defibrillation shock asynchronously. 2 joules per kg will be initial shock delivered. Then after 4 joules per kg will be subsequent shocks will be delivered to a maximum of 10 joules per kg.
What about epinephrine?
Ma'am, even after giving the shock, the patient is not resuscitated, then I would like to go for epinephrine in the doses of 0.01 mg.
You have to give epinephrine.
And if we'll assess if the rhythm is non-shockable, then like asystole or pulseless electrical activity, then we'll continue with the chest compressions.
Can you tell me some causes of intraoperative tachycardia?
Intraoperative tachycardia can be due to pain. It can be due to fluid loss or blood loss. It can be due to hypoxia. It can be due to hypercarbia, hypoglycemia, hypoglycemia, kinking of the ET tube, exhaustion of the soda line.
Yeah, that's great. So now you have revived your patient and surgery has gone smooth. And now it's time for extubation. What all measures will you take and how are you going to extubate the patient?
I'll confirm there is adequate reversal of the neuromuscular blockage, and then I would go. And if there's spontaneous, the neonate is breathing spontaneously, then I'll give the reversal. The injection neostigmine in the doses of 0.05 mg per kg, along with glycopyrrolate 0.01 mg per kg. Then I'll if the neonate is having intact cuff and gag reflex, it is breathing well, and there is a proper movements in the backs, then we can go for extubation. Also, if it is lifting the upper limb as lower limb, there's weakness, and more than saturation, more than 95% on spontaneous breathing is there. The air leak around the ET tube and the airway pressure are between 10 to 15 centimeter H2O, then we can go for extubation.
So as a protocol, we are doing awake intubation and not deep intubation for the neonates. The only thing which we keep in mind is that patient should not be coughing over the tube. So it should be gentle and smooth, but not very deep. So now you have extubated your patient. Now just tell me, we have to finish, I think. So now just tell me that if you have extubated your patient and suddenly you see that there is a laryngospasm, so what are you going to do?
I'll keep the mask. I'll give 100% oxygen. There will be, I'll take the triple manual jaw lift, head tilt, and jaw thrust. And then I'll do the laryngospasm notch massage.
Yeah.
And I'll give PEEP, a pressure of 10 to 15 centimeter H2O, and to open the airways. And
but still you are not able to do it and saturation is dropping very rapidly. Then
deep sedation, I go with propofol in the doses of 3 mg per kg, and even if then that's not helping, so I would give succinyl choline in the dose of 0.1 mg per kg.
Yeah, this is the most important use of succinyl choline. Some people use ropuranim also here, but I think we have been using it for laryngospasm, and till date I have not seen that after giving neostigmine or something its effect is too much prolonged or we have seen any complication with it. So I advocate that we are using, and it is good, and it really weans off the spasm too quickly.
Sorry
So
to
now-
interrupt you, ma'am. Ma'am, I'm afraid we are exceeding the time because we have another.
That's finishing now. Only one question left.
Okay. Sure.
So now you have extubated, the baby is breathing well. The last question is that what post-operative analgesia do you want to give to your baby?
Ma'am, in our institution, we give rectal suppositories in the doses of 35 to 40 mg per kg as a loading dose, which is followed by 15 mg per kg, and it should not exceed 60 mg per kg per day.
Okay, thank you. Very nice. You have prepared it well, I suppose, and I think it will be of benefit for rest of PGs. She's a second year PG, and I think she's worked pretty hard for this. Thank you so much. Thank you for this opportunity. Now Kanta ma'am will take my place and Dr. Dheeraj will be here.
Monica, there are many questions in the chat box related to this case. Shall we just finish them off, because afterwards, if you it will be difficult to grasp the case again.
Sure, ma'am. We'll just finish off.
So that madam can finish it off.
Yes, yes.
Finish
Dr.
it
Swati,
fast.
can you please start asking the questions?
Yeah, the first query is about role.
You're not audible, Swati.
Laryngoscope in pediatric airway, ma'am.
So, role of video laryngoscope in pediatric airway, ma'am.
Yeah, ma'am. It's very nice to use and it's really helpful in some difficult cases, although we are not using it very regularly. But we have a STOLS laryngoscope, video laryngoscope for pediatric cases, and we are using it when difficulty arises, and it's really very helpful.
The next question is RSI possible in 2 days old baby?
Yeah, it is.
So he's Dr. Vijay is asking, it's very difficult to locate the cricoid ring, is it?
Cricoid pressure is not given in controlled RSI. That is the difference. In controlled RSI, what you have to do is you have to pre-oxygenate, you have to give hypnotics, and then you have to give atracurium, and then you have to gently ventilate the patient, very gently. The difference is that here you are not giving cricoid, you are not using succinyl choline, and you are not leaving the patient in apnea. So this is meant for neonates, especially for the babies.
So the neonatal RSI is very much different from the adults. I hope you got your answer. The next is dose of atracurium. Shouldn't it be more? It was said 0.05 mg per kg for induction. Dr. Saroj is asking now.
1 second. It's the same.
Next query is about dose of atracurium, ma'am.
No, I think there is the dose of atracurium for induction in babies and maintenance. Can you be clear about that?
Ma'am,
For induction and for maintenance in babies.
ma'am, induction is 0.05 mg per kg, and for maintenance, it is 0.01 mg per kg.
I don't think so.
It's 0.5, I think, 0.5 milligram.
It is 0.3 to 0.4 milligram per kg is the range in babies.
For intubation, and
Yes.
then
Yes. Huh? Just we clarify that. Okay. Next.
One of the participants wants you to repeat mainstay auscultation.
can't hear, ma'am.
Dr. Swati, I'll speak out the questions because I think you're having some connection issues. So can you repeat mainstem auscultation? You discussed about that.
Ma'am, in mainstem auscultation, we'll keep our stethoscope over the left lung. Then we advance our ET tube. So when we are not able to hear the breath sounds,
One second, I'll interrupt. Like it's after you have auscultated on both and it is equal. Then you will keep it on the left and then advance it.
ma'am, when we advance it, then the point where we are not able to hear the breath sounds, that is the transition from trachea to the right bronchus. So we'll note that depth and we'll keep an account. Then we'll again withdraw the tube while ventilating and while hearing the breath sounds over the left chest. And ma'am, the point where we are able to hear the breath sounds again, we'll mark that point. So that point should be within 0.5 centimeter of the previous the length we've measured, and then we'll advance the tube from 0.5 to 1 centimeter from that point. That will there we'll have to fix the tube that will confirm that both lungs are ventilating. That is the Mainstay method.
So Dr. Vijay is asking, what about the angle of bronchus? Isn't it same on both the sides and the tube can go in either bronchus?
It is almost same, but still there is little difference. If you see about the foreign bodies also, even in the pediatric age group, they always go to the right side. So the little difference in curvature makes it easily to go in the right side.
So the next question is, less than what age or weight micro cuffed tube is not used?
Not less than 3.5 kg, it should not be used. Although studies are going on, but that is what books say.
Dr. Rahul is asking how to manage hypotension in neonates intraoperatively, and is it necessary to measure BP intraoperatively in neonates?
Yeah, like Dr. Mantika said, BP measuring is very important because hypotension itself is a very ominous sign. Hypotension here occurs only after we have lost at least 30 to 35% of fluid. So it can be managed by giving fluid to the patient, and after a limit of like you have given fluid and it is still like ongoing bleeding is there, then and then only you will go for blood. And in between, you can give albumin also, which is good for the babies.
So Dr. Vijay is asking that what should be the respiratory rate during resuscitation while the endotracheal tube is in C2?
Yeah, she told.
8 to 10 breaths per minute.
So she's asking, is it enough? Because the normal respiratory rate in the neonates is a bit higher.
That is what algorithm says.
There are
Dr.
questions
Mohan
about
has
dose of
asked,
epinephrine,
sorry.
dose of epinephrine, IV and endotracheal for resuscitation.
Yes.
IV, it is given as 0.01 mg per kg, and maximum can be given as 1 mg per 1 mg. And for endotracheal, while giving, we can give as 0.1 mg, and maximum can be given as 10 mg.
And ventilator strategies in these patients.
Ventilator strategies because they are very prone to barotrauma. So pressure control or pressure assisted should only be used in these babies. Initially, volume control was also used, but nowadays simply going for pressure control or pressure support is good enough. With naturally we give feed to the baby, so atelectasis is not there.
Dr. Rahul has suggested use of Teva instead of use of fluoride.
That is one thing I wanted to ask, but I missed. Teva is used very frequently in adults, and it is good for the babies also. But unfortunately, the models which are made for adults cannot be used in pediatric patients. There is one pedo fusion model which has been developed for pediatric patients, and that is only one model which can be used. But I guess in upcoming days, it is going to be as popular as it is in adults.
Right, ma'am. And one of the participants has asked if Choline is contraindicated in 2-day-old baby.
Yeah, Choline is not normally used in 2 days babies. It is almost contraindicated. The only indication to use Choline is laryngospasm, which is life-threatening, and we have to save the limb. Otherwise, for intubation purpose and all, we are not using, and neither the books are saying to use succinylcholine. Choline. But one very interesting thing I want to share is what I read while we were doing this, that Choline, we all know, can be given IV, IM, intraosseous, but it can be given in sublingually also through the submental space. That is something which I think if is shared can be life saving to somebody.
Sublingual Choline is a new thing for us, ma'am. So
yeah, that is in Miller's. I read.
Okay. We have had a quite extensive discussion, almost a recapitulation of all the pediatric anesthesia as well. Since we are towards the end of the questions, I mean, all the questions are over. Can we move on to the next case discussion, ma'am?
Thank you so much, ma'am. It was pleasure. Thank you.
Thank you.
Thank you, Dr. Himantika.
Thank you, ma'am.
Welcome, Kantavati, ma'am. We are extremely privileged to have you here. Can we have Dr. Dheeraj sharing the screen? I must say, Dr. Himantika did a very good job. She had almost answered all the questions asked by Dr. Sonali ma'am.
Yeah. Monica, here the two cases have been separated, like hydrocephalus and meningomyelocele separate. What if the two were combined?
Could have been. But the
Yeah.
active speakers, certain participants were there.
Yeah, yeah. But very often, sometimes it can be like that also.
Yeah, because most of the things are in common.
So what is operated first, the meningomyelocele or the hydrocephalus? That is the first question. So let's see, let Madam begin. Yeah.
Hydrocephalus is there because of what they've done and then. Both can be done subsequent together also. And can you proceed?
See your screen,
Visible, ma'am. You can proceed. Dr. Dheeraj can proceed.
Okay, Dr. Dheeraj, you can proceed.
Good evening, everyone. There is a 7-month-old male child hailing from Noka, Bikaner, and the informant is mother, and the information is reliable. And she brought her baby to the hospital with the presenting complaints of vomiting since 3 days, and vomiting is 4 to 6 episodes per day, non-projectile and non-bilious in nature. And she also mentions that baby is not active and fearful with reduced oral intake from 2 days. And along with that, she also gives a history of gradual increasing head size since 4 months. And there is no history of fever, no history of cough, breathing irregularities, no history of urinary incontinence, no history of diarrhea or constipation, or no history of seizures. And the baby is admitted in pediatric ward. MRI brain study has been done, which shows cerebral aqueductal stenosis. With antenatal history, is the slides are.
Yeah, now we can see. Yeah, we can see. Please continue.
Antenatal history. Health and nutritional status of mother was normal during whole pregnancy period, and mother had regular antenatal checkups, and there is no history of hypertension, diabetes, thyroid disease, infection, irradiation, or specific drug intake during the pregnancy period. And natal history, the full-term normal vaginal hospital delivery, and postnatal history, baby cried immediately after birth with no NICU admissions. Feeding history, baby is exclusively on breastfeeding and complementary feeding is not yet started. Immunization history, immunized according to the schedule. Past history, there is no history of jaundice, convulsion, or any hospitalization history. Family history, not significant in my case. The drug history, not on any drugs, past or currently, and no history of any drug allergy. With developmental history, baby is not yet attained the head control, unable to roll over, but able to recognize the strangers. Coming to the examination part, vital. Pulse rate was 124 beats per minute, regular and low volume pulse. BP was 86 by 58 mm of Hg, measured in left arm in lying position, and saturation was 98% on room air, and with temperature febrile during the examination time. Height is 68.2 centimeter and weight is 10.8 kg. Weight is more than the expected age, and head circumference is 52 centimeters. That is also more than the expected age. Mid upper arm circumference 12.8 centimeter. And coming to the general physical examination part, baby was poorly nourished, lethargic, not active and playful to surroundings during examination. Examination of the head. Head is enlarged, present with shiny skull with dilated veins. Anterior fontanella is full but not bulging. Cranial sutures are separated. Crackpot or Mckeown sign is present. In the eye examination, sunset appearance is present, and other head-to-toe examination mainly no facial anomalies or asymmetry, no neck veins engorgement, no peripheral cyanosis, and no spine deformities. And now coming to systemic examination part. Firstly, the cranial nervous system examination. Bilateral pupils are equal and reactive to light. Direct and consensual reflex are present. Upward gaze is impaired, but the other cranial nerve examination are being normal. In motor part, the tone is normal. However, baby is able to move, the spontaneously movements are present, reflexes being normal, and bilateral flexion plantar response. In respiratory system, VKS central, bilaterally symmetrical chest movements are present with bilateral equilaterality with no added sounds, and cardiovascular system examination being apical impulse at fourth intercostal place in mid-clavicular line, no palpable thrill, S1, S2 normal, and no murmurs. Per abdominally, soft and non-tender, no organomegaly, bowel sounds are present, and with the clinical history, examination part, and the MRI study complementing to this, my provisional diagnosis in this case will be non-communicating type of hydrocephalus and posted for elective ventriculoperitoneal shunt surgery.
Okay, nice presentation, Dr. Dheeraj. So your diagnosis is straightforward. Can you define the hydrocephalus?
Ma'am, hydrocephalus is the abnormal accumulation of CSF in the ventricles, either due to increased production or else reduced absorption, or else there is any obstruction to the passage of the flow of CSF.
Then how can you classify the hydrocephalus? Because you are saying that your case is non-communicating hydrocephalus. So what is the other type of hydrocephalus?
Hydrocephalus etiopathogenically can be classified into non-communicating type or as communicating hydrocephalus. And in communicating hydrocephalus, there will be no block during the ventricles, and the
no any blockage in the passage of CSF from the lateral ventricle to
fourth ventricle. Further, communicating hydrocephalus can be classified as a congenital or else acquired cause. Congenitally, achondroplasia or else craniofacial disorder abnormalities. In acquired, there will be TB meningitis being the most common cause, choroid plexus papilloma, or subarachnoid hemorrhage, or else intraventricular hemorrhage may be the cause. In non-communicating, it is further classified as again congenital and acquired causes. In congenital, and most cause being the cerebral aqueductal stenosis, and vein of Galen aneurysm can be the cause, and associated anomalies like Arnold-Chiari malformations, Dandy-Walker syndrome can be caused, and in acquired non-communicating tumors or else any post-inflammatory adhesions or else any cerebellar infarcts might be the cause.
We heard the term tactile edge. What is the tactile?
Vectoral edge, yes, ma'am. Hydrocephalus being associated with the vectoral anomalies like vertebral, anal, cardiac, tracheoesophageal, renal, and limb anomalies.
It's hydrocephalus.
Yes, ma'am, hydrocephalus.
So you can explain. You can tell me the pathway of the cerebral CSF flow.
CSF is mainly produced by ependymal cells of choroid plexus in the lateral ventricles. From lateral ventricles, the foramen of Monroe to the third ventricle to the cerebral aqueduct of Sylvius to the fourth ventricle. From fourth ventricle, by the median aperture and the lateral apertures, it is CSF is
Lateral aperture is the
and median is foramen of Magellana. It is drained into basal systems and the subarachnoid space, and from there it is absorbed back from the arachnoid granulations, arachnoid villi. From arachnoid villi, it is then shunted back to the sinuses, sagittal sinus.
So why the dilated scalp when you are present in case of hydrocephalus?
Whenever there is a raised intracranial pressure, there will be a reversal of flow of intracerebral venous sinuses. So in that cases, there will be an opening of communicating channels to the scalp veins. So scalp veins will be dilated.
You tell the Messian sign. What is this?
McEwen sign is whenever there is a dilated ventricles with the CSF accumulation. Whenever we will percuss the scalp, there will be a crack in the
purpose of the dilated ventricles. And what it sounds as Crack pulse.
Yes, ma'am.
And this crack pulse only is known as the
Maximum sign or crack pulse.
why the sunset sign is present with increased ICF.
One sunset sign is basically downward, the downward deviation of the eye, ma'am. So here the pupil will be covered, a lower border of pupil will be covered with the lower eyelid. So basically, whenever there is an increased intracranial pressure, so it will causes the pressure over the suprapineal ridges or the midbrain tectum. So it will lead to the upward gaze palsy.
Being an anesthesiologist, is it important to find out the, you have to know the cause of the type of the hydrocephalus?
As ma'am, being an anesthesiologist, it is important, ma'am. In communicating type of hydrocephalus, if the pressure is more or else acute increase in ICP, we can go for repeated lumbar tappings, ma'am. But in case of non-communicating hydrocephalus, it's not the possibility, because non-communicating hydrocephalus can be associated with associated anomalies like Bernard Carey, like 2, or else which in case tonsillar or Wernicke herniation is the possibility. So in that case, that is there. But also we should be worried during the intubation, so that excessive extension will not happen, so that intraoperative cardio no
Hello. So the clinical presentation of the hydrocephalus is varies. Do you know what are these factors?
Yes, ma'am. Due to as cranial sutures fused around the age of 2 years, so less than 2 years, the compliance of skull is more, ma'am. So whenever there is an increase in volume, it can accommodate to the certain extent. That's why the presentation will be different in the different age groups. So in newborns, mainly there will be a increasing head size or else bulging fontanelles, or else not closure of the anterior or posterior fontanelles will be the sign. And in infants, it will be again with the increasing head size, vomiting, irritability, or else lethargy, or else less playfulness. Mother gives usually this as the history. And more than 2 years, or else in toddlers, or else in children, there will be associated headache will be there, neck pain will be the symptoms, or else behavioral changes might be the complaints.
Other factor maybe the it also depends on the clinical presentation, is also depends on the progression of the disease, whether it is acute rising ICP or it's a chronic rising ICP. If it's a chronic rising ICP, even it's also compensated by the compression of other intracranial compartment. So the manifestation of the patient's symptoms is delayed in chronic rise of ICP. And it's also dependent on what is the pathological side of obstruction. So you said that the head circumference is 52 centimeters in your patient. Is it normal?
No, ma'am. It is more head circumference more according to my patient age. Usually head circumference in first 3 months of life, head circumference increased by 2 centimeters per month for first 3 months, and from 3 months to 1 year it increases by 2 centimeters every 3 months. From 1 year to 3 years, every 1 centimeter per 6 months. Every 6 months.
How you calculate that the
one head circumference is usually calculated by occipital protuberance to the frontal, occipital frontal head circumference is taken.
Why do examine the other organ system? What's the importance of examination of the other organ system in this in your patient?
Hydrocephalus is per se might be involved with other systems, like other congenital anomalies are more common. If there is any facial deformities, it might pose difficulty in our airway management in further case, or else if any spine deformities, we should take care of about that, or else if any cardiac issues.
Which spine deformity is common with hydrocephalus?
One hydrocephalus associated with meningomyelocele is common. Spina bifida is common, and encephalocele is common.
What are the cardiac abnormalities maybe associated with this?
Cardiac abnormalities usually cyanotic heart diseases, ma'am.
DST, EST.
Yes.
You said that your patient having upper gaze palsy. Yeah. And which other cranial nerves are affected in hydrocephalus?
Ma'am, whenever there is an increased intracranial pressure, the first nerve to be like involved is sixth cranial nerve, usually due to its
Why
longest.
sixth cranial nerve is affected?
Ma'am, it is having longest intracranial course, ma'am. So it
And
might
it's also more sensitive to pressure.
yes, ma'am. So it might get compressed against the petrous ridge of the temporal bone. So lateral gaze palsy might be the sign, or else, ma'am, other
Lateral gaze palsy is usually seen in with supratental.
and then 10th nerve, vagus nerve can be involved in the jugular foramen where it will be taking the acute turn during the increased ice.
So when the vagus is affected, can you find any clinical finding in the patient?
Yes, ma'am. If bilaterally vagus nerve is involved, there will be the bilateral vocal cord palsy. So Strider will be the finding in the patient.
What other, if your patient is having other neurological abnormalities, although your patient has the respiratory system is absolutely normal, can you find any other complication with respiratory complication with this in this case?
Ma'am, first of all, due to they are prone to infections, respiratory infections.
Recurrent
And,
respiratory infection or
Whenever there is a raised breathing pattern will be irregular, and then neurogenic pulmonary edema might be
Yes. And there is increased risk of aspiration because it's thought that the patient with increased ICP have delayed gastric emptying. So what are the treatment modalities for hydrocephalus?
From hydrocephalus, if there is a gradual increase in the head size, so treatment modalities will be either medical management or surgical management. In medical management, ma'am, we can use
Medical management we usually consider when there is a slow and steady rise without any presentation of pressure symptoms, yeah, any sign clinically asymptomatic patients.
in medical management, ma'am, we will use furosemide or acetazolamide, ma'am. But nowadays they are telling in infants and children the role of diuretics is controversial, and for definitive modality till now for hydrocephalus in the surgical management, usually we will with acute rise in that condition we will go for ventriculostomy or else EVD, or in other conditions if the time is then we will go for CSF diversion procedures like ventricular peritoneal shunts or else ventricular atrial shunts.
Any other shunt you know?
Ma'am, ventricular pleural shunt is also there, no? And nowadays
Ventricular sickle shunt, but most commonly is when ventricular peritoneal shunts. And what are other modalities? Extraventricular.
Endoscopic third ventriculostomy also can be done.
What is this?
Ma'am, in endoscopic third ventriculostomy, small hole will be created using endoscopy in the floor of third ventricle. So this will help.
This will bypass the stenosis. The
So
CSF is directly goes into the basal system. Okay. So now your patient is having the large head size and have vomiting since 2-3 days, 7 months of babies. So what difficulties do you expect in this patient?
As the baby is having already large head size, so I'll be having concern of difficult airway management, and as baby is already having vomiting, I should be considered about the difficult IV access, and the dehydration might be the part. This electrolytemia also might be the concern, and hypoxemia might be the concern now. And in raised intracranial pressure, delayed gastric emptying is also the concern.
And one more temperature about the temperature.
Yes, ma'am. Temperature as body surface area of the infant is will be the more. So temperature loss will be very rapid in this cases.
Okay. So now the patient is posted for elective ventriculoperitoneal shunt. So what the fasting instruction you want to do?
Ma'am, I will go with the fasting instruction of like nowadays what we use NPO guidelines. I'll go with that for solids 6 hours and for formula milk 6 hours. And for breast milk it will be 4 hours and for clear fluids 2 hours. As my patient is 7 months old and still on breastfeeding, I'll tell mother to 4 hours before breastfeed and 2 hours for clear fluids.
Nowadays is that the gastric time for gastric emptying is reduced to 30 minutes. But in your patient, because the ICP is increased and there is chances of delaying of gastric emptying, so you can instruct the mother to give the clear fluid before 1 hour of posting. If your patient is taken for the emergency surgery, then what the points you consider at the time of preoperative evaluation? What are the important points do you reconsider in this patient?
If I'm taking this patient for emergency procedure, I should prophylactically prophylactic antibiotic should be started so that shunt related infection will be reduced and fluid deficits should be corrected according to the dehydration status, and the electrolytes should be managed accordingly.
But nail by mouth, so this status should be asked for because
risk of aspiration
is more in patient and time is taken from the last feed. So, do you want to optimize your patient preoperatively if it's taken as a elective procedure, and how?
If time permits, if it's an elective operation, I want to optimize definitely enough. Prophylactic antibiotic should be started. Prophylactic antiemetic should be started, and hypoglycemia should be corrected, and fluid deficit should be corrected. That is the main.
How you calculate the fluid deficit in this patient?
But nowadays we will be using the dehydration status. If skin turgor is less and skin turgor is and dry mouth, that is that, then we will consider it as mild dehydration and we will go with the 50 ml per kg. And if it moderate dehydration like sunken fontanelles or else tachycardia are present, then we will go with 100 ml per kg. And if baby is having hypotension or else anuria or lethargy, in that cases we will consider it as severe dehydration and we should go with more than 100 ml per kg as a rehab.
What investigation you asked for this patient preoperatively?
Ma'am, I will ask for complete blood count. Ma'am, I should know the complete blood count. Hemoglobin is important so that the adequate amount of blood is if needed, I should be ready with that. And the WBC count is important because whenever there is an active infection with high counts, so VP shunt procedure will not be done. Many of the times EVD will be done. Later, ma'am, I will go with the serum electrolytes as baby is already having vomiting. Then I should go with the fasting blood sugar or else random blood sugar if possible. Then along with that RFT, LFT and viral markers to be done. And if any anomalies are associated according to coexisting diseases and morbidities, I should order specific investigation.
Okay, good. So, what are your preoperative concern about this patient?
And preoperatively, I should be mainly first. I should be worried about the consent. I should properly explain the procedures, what we are going to do, and what are the anesthetic techniques we are going to adopt in the OT, and everything should be explained as it will be the procedure to the patients and
patients parents are caretaker, and to console them, parents are caretaker. That although the baby is small and there may be just chance prognosis may be poor, but we can Okay. And or other anesthesia concern, goal for anesthesia concern.
Anesthesia concern, we should mainly anesthesia goal is intraoperatively preventing hypercardia, hypoxia, hypotension, and maintaining the cerebral perfusion pressure is important.
What is the what do you mean by cerebral perfusion pressure? What is this?
Cerebral perfusion pressure is mainly difference of mean arterial pressure with minus of sum of
Difference in the mean arterial pressure. Sum of the
CVP plus ICP.
okay. How we maintain this?
Mean arterial pressure can be maintained mainly by giving fluids or else using inotropes or else vasoconstrictors can be used. And to reduce the ICP, we can use sedatives or else hyperventilation, mannitol, analgesics can be used. And to reduce the CVP, we should be head up position can be used, and extreme neck rotation should be avoided.
Is there any difference in the cerebral blood flow in infants and adults? What is the cerebral blood flow in infants? It's 100 ml.
Yes, ma'am. In adults, it is 50 ml per 100 gram
per minute, and in infants,
it will be 100 gram. Ma'am. In adults, it
100
will be
ml. 100 ml per 100 gram
per month.
per. So the cerebral blood flow is high in infants. So as you are expecting difficult airway in this patient, what are your OT preparation for this patient?
As I'm expecting difficult airway, even though difficult airway, I should be prepared with whole and soul with of the OT preparation from suction, oxygen delivery devices, and proper anesthetic equipments with all the monitors, parameters, whatever I needed, it should be ready. And, mainly regarding the airway management, appropriate size face masks.
What do you mean by appropriate size of face mask?
Ma'am, from glabella covering to the
cover from
glabella to the appropriate size face mask should be ready. Oropharyngeal airways, endotracheal tubes, LMAs, and shade blades, like Miller blades of all sizes should be kept ready. And head ring and shoulder pads or bolsters should be ready so that to make the position. Or else NG tube, orogastric tube also should be ready if whenever the stomach is inflated to deflate this.
Why we not put the video laryngoscope if you are
Yes,
having in institute?
Yes, ma'am. If
We are having in
yes,
institute.
ma'am. In institution like where video laryngoscope is present, in difficult intubation cases like this, we can go through with video laryngoscopes.
Okay, then your baby is coming in protein. So what the monitoring, what monitoring wants to attach these patients?
Ma'am, I will monitor for heart rate, ECG should be monitored, BP should be monitored, and ETCO.
Non-invasive, invasive.
Ma'am, if I'm not expecting much fluctuations, then I will go with preferably with the non-invasive BP. If I'm expecting fluctuations in the BP involving the brainstem related areas involvement, then I will be going with radial artery cannulation. And
Is there any advantage of using the invasive IP in these patients?
Yes, ma'am. Directly because of invasive monitoring, we will be directly knowing about the mean arterial pressure, so that we can roughly estimate the.
It can guide
Guide
us to maintain the cerebral perfusion pressure. Okay, and what are the monitorings?
Ma'am, ETCO2 monitoring capnography, and MAC should be available if possible, so that the anesthesia inhalational agent MAC we can know, and temperature monitoring is also important.
So, what will be your anesthetics plan for this patient?
As the infant is 7 months, so usually it will be having less functional residual capacity. So proper pre-oxygenation is at most.
Do you want to give the sedatives in preoperative area to your patient? The patient is lethargic.
No, ma'am. I will preferably avoid giving sedative in this patient. If baby is irritable or non-combative in that, in like children, in that cases, I will prefer giving titrated doses of midazolam, oral or intranasal.
Proceed.
And then I will be after the proper pre-oxygenation. I'll, in my case, after baby is lethargic but IV cannula is secured, I'll preferably go with IV induction. IV induction with propofol in a dose of 2 to 4 mg per kg, or else thiopentone in a dose of 3 to 5 mg per kg. And if the IV cannula is not secured, in that case, we can induce with the inhalational agent, preferably sevoflurane, which is non-irritant. So that also we should use for short period so that IV cannula is secure. So that it will not, as sevoflurane is increases cerebral blood flow and it will further increase ICP.
We can then hyperventilation is this patient with increased ICP.
We should preferably avoid hyperventilation in these patients.
Prolonged hyperventilation.
Prolonged hyperventilation should be, as it will decrease the partial pressure of PaCO2 and it will further leads to the vasoconstriction of the cerebral blood vessels. Though it will reduce the ICP and cerebral blood flow, but it comes at the expense of decreased oxygen delivery. So risk of brain ischemia will be more.
Risk of brain ischemia is more when there is a decrease in is associated with a decreased mean arterial force. So therefore further there is a decrease in the cerebral blood flow. What is the advantage of using propofol and thiopentone? Our inhalational agent?
Ma'am, propofol and thiopentone, it will be like thiopentone is cerebroprotective and propofol, and both maintains the autoregulation, and also though they decrease the cerebral blood flow, but it simultaneously decreases the cerebral metabolic rate also. So it will help. And when CO2 reactivity will be present, even though, and propofol is a good anti-nausea effect also, and also decrease the dose of inhalational and opioid interoperability.
What is the auto-regulation? What do you mean by auto-regulation? What do you mean by auto-regulation?
When cerebral perfusion pressure is maintained with when mean arterial pressure is between
Cerebral perfusion patient, the cerebral blood flow is maintained within a constant range of cerebral perfusion. And what is this range for adult and infants?
in adults, it is 50 to 150 mmHg.
What is the lower limit for infants? Lower limits goes further lower down, and it's thought to be the 40 millimeter. Then you induce the child with the IV induction agents.
Later, after the induction, so muscle blockade, muscular blockade should be preferably done with the non-depolarizing. If
What is the position of your patient on OT table?
patient head should be supported with the head ring, and whenever difficult intubation is present.
Whenever your patient is of difficult intubation because it's having the large head size, your head circumference is increased as more than 7 centimeter of expected head circumference, and increased head size causes the neck flexion.
In that cases, shoulder pad or bolster should be kept so that the intubating axis will come align.
Okay. Then
after the positioning is important. After once the positioning is there, and later after intubation, giving the position to the surgeon is also important, so that the extreme neck rotation is not done. So that extreme neck rotation will further lead to increase ICP.
do you want to give the Choline in this patient?
Ma'am, in my institute, as Sugammadex is not available, so as it is a case of difficult intubation, so there might be a case of can't intubate, can't ventilate situation. So I will prefer for schooling in low dose now.
Choline increases the cerebral blood flow
Yes, ma'am, but
and ICP.
ICP is increased, ma'am, but coming up, seeing the risk versus benefit ratio. So benefit ratio is more in this case.
Increase in cerebral blood flow and ICP is very transient with insulin.
Okay.
And it can be combated by giving the defibrillating dose of non-depolarizing muscle relaxant or by dipping the anesthesia with inhalational or IV. Okay. Then
Ma'am, intraoperatively, the ventilation part. In ventilation part, I should maintain mainly normal apnea, and PEEP should be minimized because PEEP further increases neck congestion, neck vein congestion. So PEEP should be given whenever there is difficulty in maintaining the oxygen status during intraoperatively. And maintenance of anesthesia, I will proceed with mixture of oxygen with air and volatile inhalation.
which volatile anesthetics?
I will go with sevoflurane.
Why?
Ma'am, sevoflurane, though it increases the cerebral blood flow in a MAC of 0.6 to 1, it minimally varies the cerebral blood flow. In whenever it is more than 1 MAC, that time cerebral blood flow is varied much.
Maintenance on anesthesia. What is your estimation plan for this patient?
Ma'am, as I had a difficult intubation, so I will preferably go with awake extubation after proper reversal of neuromuscular blockade with neostigmine 0.05 mg per kg and glycopyrrolate. If using glycopyrrolate, that is 0.01 mg per kg, ifadropine 0.02 mg per kg after the proper reversal of neuromuscular blockade and after proper awakening of the patient, then only I am going to extubate. And if there is any neurological deficits are present, then I will go with post-operative mechanical ventilation and to extubate later.
You are using sevoflurane. What the complication with respect at the time of estimation with the started estimation?
Ma'am, studies tells sevoflurane causes more of emergence, delirium, and agitation once the post-operative delirium.
What do you mean by emergency delirium?
Emergence delirium is once the emergence baby or like the patient is not having the fully consciousness, but he
But not aware of
not aware of surroundings.
not responding to parents or staff. So there are various surgical steps. At what surgical steps you expect that the hemodynamic fluctuation can occur? And how will you manage this?
Hemodynamic fluctuation mainly during incision, first surgical incision, and during tunneling to put the BP shunt. So that time I'll be expecting the tachycardia and raised ICP. So to prevent that, I will preferably use fentanyl in a dose of 1 to 3 microgram per kg at that time.
And when the surgeon putting the catheter in lateral ventricles, there is sudden release of pressure and it will shift the midway upwards and there may be chances of bradycardia and respiratory arrest, cardiorespiratory arrest. So how you will manage post-operative pain?
Post-operative pain will be managed with combination of infiltration of local anesthetic using bupivacaine 0.25% in a dose of 0.5 to 0.75 ml per kg.
Where you ask to give the surgeon at which incision site?
Incision site to put the
at the abdominal incision.
Abdominal site. And later PCM in a dose of 15 mg per kg can be used. If NSAIDs are not contraindicated, then we can use NSAIDs.
in your patient, you want to do the ICP monitoring?
As the procedure is short, which includes 40 to 60 minutes, I will not go with ICP monitoring now. And the baby is not having so much increased ICP in my case, so I preferably.
What are the site for monitoring the ICP?
ICP monitoring can be done usually like subdural or else brain parenchyma, can be or else gold standard like directly by doing EVD and inserting in the ventricles.
Is the gold standard for monitoring the ICP? So, what is the oxygen? What is the cerebral metabolic rate in infants? It's less than adult or more than adult?
Cerebral metabolic rate is more than
Cerebral metabolic rate for oxygen.
it's more than
How much? It's in adult it is 3.5 ml per 100 gram per. And in infants, it's about 5 ml per 100 grams per ml. So you very well answered all the questions. So any questions from audience, madam?
Yes, ma'am. Shall we proceed with the questions then? The first question is, which type of fluid is preferred in neonates? I think it was addressed during the sessions.
Which fluids preferred in infants? We are using
fingers like it.
balanced solution is
Isotonic solutions are preferred.
balanced solution. Isotonic, it is slightly hyper.
Next is about delayed gastric emptying time, ma'am. Should we go for more NPO time because of delayed gastric emptying time?
No, it's can you answer this?
Ma'am, nowadays studies tell where there is no chance, where there is a possibility of delayed gastric emptying, then we will keep for clear fluids for 2 hours. If there is no such things, then nowadays studies say gastric transit time is 30 minutes. So in that preferably 1 hour fasting for clear fluid is more than enough.
So the main aim is to decrease the preoperative time for the preoperative fasting time for patient infants.
Yes, ma'am. These days, gastric ultrasound is also used to look for residual gastric volume and then decide about
residual gastric volume.
Next is about thecoperitoneal shunt. They have asked if it has to be done many times.
Yes, madam, it can be done, but in our institutes, we are not. Surgeons are not done.
And rationale behind using straight blade only in neonatal intubation.
But because the child is 7 months, it's good for do the intubation. We can do it with curved blade also, but we are having the video laryngoscope in our institute. So usually we prefer to do the intubation with video laryngoscope.
Okay, ma'am. And Madhuri ma'am wants to say something.
Yeah, that's this ventriculoperitoneal shunt. You may even get a case for repeated procedure, especially when the child overgrows. The child grows and the shunt becomes short. So it is taken for, you have to put a new shunt or you have to lengthen the shunt. So it is taken repeatedly. It can be taken up. And one more thing is regarding delayed gastric emptying. I do not understand why there should be delayed gastric emptying in this case. The vomiting is due to the raised ICP, right? And these children often have tuberculosis, which is the most common cause of hydrocephalus in our country. So they'll be very poorly nourished. And it may be a case of posterior fossa tumor with hydrocephalus. If that is the case, then again raised ICP is going to cause all the vomiting, and the child is going to be very, very undernourished in these cases. So the chances of hypotension soon after induction are very, very high, as you have said. And regarding that blades, Dr. Dheeraj, can you tell us a different type of laryngoscope blades which can be used in this baby?
We can use straight blades or else curved blade like Macintosh can be used. Then video laryngoscope like C-Mac blades can be used. McCoy blades can be used.
Yeah. So the main rationale straight blade is you can lift the epiglottis with the straight blade, knowing
Yes.
the difference in the anatomy of the airway anatomy of the neonate, right? So you can lift the epiglottis and you can view the glottis better with the straight blade. That's the rationale. And what about the use of a supraglottic airway device in this baby? Suppose you can't intubate at all, you have induced. Then
Yes.
would you go in for a supraglottic airway device?
Yes, ma'am. According to the airway management of EPA guidelines, whenever there is a difficult mask ventilation or else difficult intubation, so we will preferably should be ready with the supraglottic airway devices, ma'am, of all sizes.
Yeah, and how will you nurse the patient post-operatively, hydrocephalous?
Ma'am, post-operatively, the main concern will be the consciousness level of the baby and the hemodynamic.
The most important is the to don't remember the venous drainage. So child should be put in slightly head up position. So there is venous flow is from the brain to neck is not obstructed, and otherwise it will further increase the IC. Okay.
Dr. Rajiv Jindal, he has actually asked why is straight blade preferred over curved blade? He wants to know the reason.
I think Madhuri.
Yeah, I think Dr. Madhuri has just answered Dr. Swati this question. Ma'am has just taken up. We can move ahead.
Any more queries regarding meningomyelocele?
You can unmute and or raise your hands and then you can speak if you have any queries.
Any of the short cases, either the first one or second one.
So, first of all, I'd like to congratulate Dr. Dheeraj and Dr. Himantika and Dr. Nishant here. And they have actually prepared very well, very nicely prepared, both of you. And an excellent work done by both of you. It is not easy for postgraduates and residents to present in front of the whole, so many people in the country. Just one small question for Dr. Dheeraj. Traditionally these shunts are placed on the right side, correct?
Yes, sir.
You know the reason?
Sir, basically shunts are placed using lateral ventricle, lateral. Most thinking dominant side, majority of the people are right hand.
Yes.
Right-handed, so the hemisphere will be left. So thinking that will be placed in the shunts.
Bajwa sir. Sir, good evening.
Good evening. Sorry, I could not attend the class completely. I attended in between. One of the student is sitting behind the madam. I didn't see that. I think she must have finished that, no?
Yeah. Yes.
The second, and whatever the comments I think just heard from Dr. Madhuri and Dr. Nishant, the student must have done very well. And I think kudos to Dr. Kanta madam and Dr. Sonali. They are doing an excellent, good job.
Thank you, sir.
Actually, I would have come there as examiner also, but I think this is a good one.
Sir, you are most welcome.
I think you can be proxy examination is a good one on online. Students are there are so many, so we can have merits 1, 2, 3, 4, 5 online examination, and we can have demerits of offline examination, isn't it?
Yeah, that's a good answer.
I can see so many good people are there. Dr. Ratnakar is there. Sir, unmute yourself. Just wait. Let me make it. Dr. Ratnakar, you are very much regular in the classes. Sir, unmute yourself and you also contribute toward the suggestions for the classes. Unmute yourself. I will be meeting you very soon in 3-4 days.
Yes. Welcome, sir. Welcome to 8th ISACON Telangana State Conference. Please welcome. This is at Khammam on 14th, 15th, 16th of this month. And the lectures are very good, selected by very dynamic people like you. And the topic very interesting, and it's a challenging topic. Hydrocephalous and
especially in the neonate, it's always a
yeah,
very
it's
challenging
very
part.
interesting. Yeah, I'm really attached to this pediatric one, but interested in learning.
Yeah.
So I do most of the general surgery and gynops. So, and congratulations all. Thank you.
Thank you, Dr. Thanaka. Whatever the type of anesthesia we give doesn't matter, but when the students are appearing for the examination, it kindles, something query in every teacher who's sitting and they're watching this question and answer. They also want that I should answer, I should question this, I should question this. Sometimes you feel, oh, in my time I didn't do this. The people are doing that. So things have gone advanced, I think, and the time we did our MD and this time many changes have come, especially in the anesthesiology and intensive care. Many advancements have come. If you look at the 20 years back, the type of anesthesia at that time, the propofol was very new. It was very new. It just came, and after that, I think the advancements never ceased to come. Coming the naitomidate and all other drugs. So many things have come, and not just drugs, the techniques. Rather, just from this one airway, new airway gadgets, the airway techniques, then coming the other parts. Those monitoring standards and ultrasound guided. Within 20 years, the anesthesiology has advanced, it has grown from a teenager to a very mature adult. So this specialty has gained importance, and the students, I think they're very, very lucky to have teachers who have seen the transformation. There were teachers before us, and there are teachers who are going to be now teachers. We are the transformation teachers who have seen the both hand side of the world, listening from their experiences. And I am not well versed with many of the new techniques also, because the learning curves, they come very, very good between 25 years to 40 years. After that, the learning curves get very somehow subtle. You may not be learned. Sometimes you feel shy to learn. Sometimes you have so many inhibitions. So these students
are doing such a great job, and I can't think that you can afford to have time. You are doing such a great job on the ISA platform. We all are so proud of you. You have introduced so many new things. So that is the part where you are
introduce so many persons here also. Introduce the platform to residents also. Sir.
That is a part of the office also. As a part of office also, you have a vision, your individual vision also. Then as a part of the office, we have to do these things. And see, academics have to come forth now, because once anesthesia are already advanced, so the stress has to be on the academics. And without the contribution of individual teachers, individual students, the students, I think, they are our future, and they have to be brought up in such a manner that they continue to do good, not in their academics and examination, but they should continue to get associated with ISA, make it more academic body in the coming days. Because after 10 years, these students who are appearing for today on the online examination, they are going to handle the many things in ISA. So just like younger people like that, Swati is there now. Just senior to her is Monica. They are doing such a wonderful job. Nishant has been doing, and Dr. Madhuri, she is, I think my proxy is there. If I am not there, she is there. So these things will continue, and many more the youngsters are coming up. The idea is to bring such a force in the academics that ISA should be making a global presence felt in the coming years. And the idea is on that. The vision is there, and these online classes now presently they are very much present on the YouTube. And when these are seen globally, ISA web going globally, and people seeing these classes, at least it will also stimulate them to start their own programs.
Yes.
With the change of the attitude, with the change of the pattern, and with all the new crisp and clip, and some more UG classes are also going to come very soon. I think on Independence Day, we are planning to launch the UG classes, and that will be monthly or maybe 15 days, because those don't attract. And many of the demands of the anesthesiology member, they say that the UG curriculum should be modified, our anesthesia should be given importance. You will get importance only when you make your presence felt. And moreover, the examination pattern, the question pattern, and the marks pattern in the UG examination will make anesthesia grow much, much faster as compared to this PG curriculum. So I think that we are on target, and a contribution of everyone is required here.
So
People are doing. doing good job. And today I really thank Dr. Monica and Dr. Swati and Dr. Madhuri and Dr. Nishant, because I know this is on auto mode now. The classes are on auto mode. Everything, whether I'm here or not, this is the pattern. The class should go on auto mode. The show should go on inhibited by nothing. That's what the motive is behind all this stuff. Anyway, your feedback, madam. Last, just want to hear Dr. Kanta Bhatti's and Dr. Sonali's feedback also from the classes. We want some more constructive from your side. What we can do to make it better.
Yes, sir. One thing जो अभी आया था कि हमारी ऐसी क्लासेस हैं जो कोविड में शुरू हुई थी and it is continue. And various other subjects are also doing this in COVID time, but these classes are stopped. So it's very proud of you that you maintain this until now.
Yeah, today I could not attend because of some commitments, but I reached home late because of the floods. I came from Thrissur today when I landed.
I would like to thank you and thank all the core members for giving us the opportunity and for, like you said, for betterment. I guess like this is a very good thing that we are taking all the practical aspects. Similarly, we can go for theoretical things also, like the important systems, system wise, we can divide it. And what like cardiovascular system, it is so important for us. So we can divide it in major parts, and then we can go for that also. It will also be very helpful for the PG students, I think so. Because
yeah, theory classes are going on, but just for this little change, we did it to the short cases and long cases.
I think for PGs who are going to appear, they'll be really beneficial.
Yeah, theory part will be starting very soon. Theory part, because long cases are going to come to an end, and then we can have a newer long cases and short cases later on, diagnosis, spot diagnosis, everything. So the pattern is going to change a little in the next 1 month. After the July, this one July is over, or August, the first part is over. From 15th August onward, the pattern is going to change. So this pattern, I think everybody is able to view this pattern on the YouTube. All these long cases, short cases, majority of these cases come in the examination. So they will be able to know majority of the questions and answers. That was the aim. So YouTube, they can continue to watch. And we are going to continue to improving. Anybody else want to give a suggestion on the classes or want to give something?
Can I speak something, sir?
Yeah, please. Dr. Mazumdar.
Yes, sir. From Agartala.
Congratulations for your very good that one.
Thank you, sir.
Workshop.
Focus workshop. Yeah. Yes, sir. It was very good yesterday.
Yeah.
Sir, for that presentation and discussion was, sir, very good. Only my one suggestion for postgraduate students, that shifting part is very important. You have monitored, you have done everything very well. Just few days back, we lost one child. That the postgraduate students, you accompany the baby throughout the shifting process, transport to the ward or ICU, pediatric ward, wherever it is, and never depend on the OT technician. That is my suggestions. That is
institute.
It's a very good suggestion. Even you are talking about a PG student. I think my HOD used to send me when I was AP also to with the patient. And not forget about the PG. PG, they don't believe the HODs. They believe at least senior resident or a AP student, AP, the minimum assistant professor who can transport it. I think it depends also upon the protocols from institution to institution also. But definitely the transportation is very important. The technicians we cannot depend upon. Medico-legally also, they cannot be protected if something happens on the way. So these are the, I think, the transport and shifting. Very soon the focus will be shifting on these parts from the government side or from the NGOs, that because every day you are hearing the news, and you know ISA headquarters is trying to prepare replies to all those things to the bodies, authorities, and all the things, just like NCRT case and all those NMC things. So many things are there. Tomorrow another case will come, and you know the headquarters is just getting stuck in replying to these type of things only. So this definitely we have to have some protocols. This is a good suggestion. We can have some national protocols to be followed. I think from ISA side, Nishant and Dr. Madhuri, you are listening, na? So try to at least, we will be forming the protocols, make a point on it. The next time we will be making advisory rather, not protocols, advisory from ISA regarding the shifting of the patients. I think this is a good suggestion. Just बात करते करते दिमाग में चीजें आ जाती हैं तो अभी लिख लेते हैं, इनको करते रहेंगे. मेरे दिमाग में चीजें भूल जाती हैं. एमनेजिया हो गया, रेट्रोग्रेड एमनेजिया चल रहा है, ग्रेइंग हेयर मैटर चल रहा है, सारा कुछ जो भी चल रहा है ना. तो आई थिंक यू पीपल आर देयर टू हेल्प मी आउट. आज मनोज भी नहीं है, नहीं तो मनोज keeps remembering everything what I say, na. So you keep remembering those things. Thank you, Dr. Bhaskar. It was really good. Manoj told everything about the workshop.
Thankful to PG Online committee, and also thankful to my HOD, Senior Professor Dr. Anita Parekh, who advised me and helped me to prepare these two students, and also thankful to Dr. Agalya. She is our senior resident.
She's very sincere.
Very sincere.
Hello.
And Dr. Kivi also, she couldn't attend this because she's gone for some meeting with the district collector, so she missed it. I'm very sure she must be watching, and we are really thankful to everybody who helped us, and especially you people. Thanks.
Yeah. Thank you, ma'am. Thank you. Dr. Monica, you close the session formally. Swati, thank you very much. So you are confident now to hold the classes in the future. You must have got the pattern, because these senior coordinators always remain with you people. That is, I think, the building of the confidence. Tomorrow you may be anchoring the things after some time. So that's good. So Monica, you can close the session formally also.
Yes, sir. So one more thing I would like to point about the team of Kanta ma'am and Dr. Sonali is that they were sitting together and presenting the case. That I think ma'am is new to ISA online PG classes, and it was much more interactive and it was much more involving. So thank you for that. And I thank all our postgraduate students and all our participants for making these classes success, because without you, we are nothing. So with that, I would like to close the session. Thank you, Dr. Bajwa. Thank you, Madhuri ma'am. Thank you, Dr. Nishant. Thank you, Dr. Swati. And thank you for the team of Dr. Kanta and Dr. Sonali.
Thank you so much.
See you next Monday.
Yeah, Monday I will be telling the topic in the SMSs only on the WhatsApp. Topic has not been decided. We want to bring a good topic. The teachers have been decided, the students have been decided, the topic still searching. It's a good one topic we will be bringing up.
Jai ISA and long live ISA.
Long live ISA, Jai Hind.